Good afternoon, everyone. And diagnosing progression is a challenge you accept when you treat even one patient of glaucoma. And more so when you choose glaucoma as your subspecialty, it's easier to diagnose glaucoma, but it's difficult to diagnose progression. It's a 6-minute talk. This will be just a general overview and not a detailed one. So, how do you diagnose progression? You have to have a certain plan. And just a minute, I will. You have a pointer?
No, ma'am. Laser pointer, please.
Yeah. So, it involves surveillance planning, data collection, analysis. Yeah. And because glaucoma is a slow, chronic, silent disease, and regular follow up is the backbone of assessing efficacy of treatment, that is progression. And that is one thing at diagnosis, you have to sort of drill it into the patient's head by repeating it again and again and again. And it involves 4 steps: surveillance planning, data collection, analysis, and interpretation. So, what is surveillance planning? How often should be the follow up? How often should we do the tests? So, higher IOP, advanced field damage, younger age, positive and severe family history warrant closer follow up and more number of tests. So, progression can be detected only and only if you know what you started with. So, if you want to know if I'm worsening, you have to know what you began with. So, establish a good baseline, and that's the first principle of diagnosing progression. So, what do you mean by establishing a baseline? The challenge is there is no single test which on its own can diagnose progression. And so, the baseline is established with functional tests like perimetry and structural tests like disc photographs, OCT. Mind you, I am writing OCT as the last. OCT. Each has a different sensitivity across the glaucoma spectrum. In an advanced glaucoma, OCT is useless. Perimetry is across the glaucoma spectrum. Perimetry is the test to do. And so, if your patient can afford only one test, it should be perimetry. All right. So, another challenge for me in private practice is getting patients to do all these tests because they are charged and they require to do it every 6 months, and that takes an extraordinary ordinary amount of counseling, but it has to be done. That's part of your job. Okay. So, how do we analyze? So, we have collected data. I have told you how often to collect the data. How do we analyze? The analysis can be either manual and with statistical support, and in most cases, we use both. So, how do you analyze? The simplest method of detecting disc change is serially examining photographs. This is one lady who, in 2015, had these nerve fiber layer defect, which has not really translated into disc damage. 2017, you can see it a little bit more clearly, and in 2020, you see it has enlarged. So, this is progression on disc. You don't know who's going to progress. So it should be done as a discipline in every glaucoma patient. That's one thing. Now, this, and as I said, it's a discipline because I didn't know she was going to progress. 2015 to 2020, it has taken 5 years for her to progress. OCT, when you have fewer scans, you eyeball the scans. But if you want to say that OCT is a very precise machine, this superotemporal quadrant 129 is the measurement. After 6 months, it became 137. After another 6 months, it's 124. So, fluctuation is part and parcel of any machine, even OCT, which is claimed to be very sensitive. And then, how much change is significant? It is said 5 to 7 microns because that's the resolution of this machine, but this tells you that no, you can have much larger fluctuation even when even with OCT. If once you have enough number of tests, then you have this kind of a guided progression analysis, and it is you have 3 scans. The baseline tests are compared to the tests here, and you have various graphs which show here it's obvious even on just eyeballing it, and plus the graph also shows progression. Perimetry is the mainstay of diagnosing progression across the grades of glaucoma severity. Again, for the first 2 to 3 fields, one has to eyeball the fields. A large proportion of the tests from a single field test will give you false positives, and hence the CNGT, the collaborative normal tension glaucoma study, suggested that one confirmatory test is not sufficient. False positives will still exist, and hence you should have 2 fields, and therefore clinicians should obtain a second and or also a third field. And here it you will see in the guided progression, the glaucoma progression analysis, the fluctuations are higher with damaged areas and fluctuations are a norm. In fields with very highly damaged field like this, 10-2 is mandatory. It gives you more to play with. And there is no statistical support. The statistical support is only for mildly and moderately damaged spots. And here it's when it's you and your experience, and it's just for my colleagues that it's very difficult to diagnose progression in advanced glaucoma. So it would be better if you're treating such a patient, at least have one opinion from your glaucoma colleague, and that will really help you. So in disc, how do you interpret? Just 1 minute. I think I've exhausted 6 minutes. Just 1 minute.
Oh, no problem.
Yeah. So interpretation is correlating all the data with the clinical picture, the complete clinical picture, including the intraocular pressure and all the other things that you've been doing, and the vision. So sometimes it's very easy. Now this is one patient, 3840, high disc damage. This is in 2011, right eye, left eye. 2014, 2019, he comes back, one eye no PL and the other eye such an advanced field. This is very easy. You don't require to really think too much, and it's easy. Now when one test shows progression and other does not, then what do you do? For example, in this patient, the intraocular pressure was normal, perimetry is normal across 5 years, but the OCT definitely shows progression. So now is the dilemma. Do you treat it as glaucoma? Do you treat it as just observe? The answer depends on the clinical picture. If the intraocular pressure remains high, one might consider it as progression. But to date, most of us glaucoma guys, we rely more on disc photographs. Perimetry is considered the hallmark. So maybe you may alter treatment based on this, but you may not make surgical decisions based on just OCT progression. So the challenges again are, there is no single test which tells you progression, multiple tests to be repeated periodically as a discipline, test retest variability across all modalities, and all tests do not concur always. And that's when perimetry disc photographs take precedence over OCT. Convincing patients to undergo these tests has been a challenge in my practice. And thank you all for a very patient listening.
Thank you, ma'am. Indeed, it was a very beautiful presentation and giving us so much of courage that how to face the challenge, accept the challenge, and diagnose the